So, good morning and happy February to all the fellows from the North and South, East to West Coast, and around the world. Welcome to the Fellow Project monthly webinar series. Today's topic is perioperative management of the adolescent patient undergoing bariatric surgery. And we have our esteemed guests, Dr. Janey Pratt and Dr. Kanika Bowen-Jallow. But before we introduce our speakers, I want to turn it over to my colleague, Dr. Shaina Eckhouse, to give some announcements.
Thank you guys for joining. Thank you, Dr. Wilson. As a reminder, our annual meeting's coming up May 3rd through May 7th. Please register for some of the specialty courses that can be good, especially when you're starting to look for your new job and think about your practice. There's also a research grant. So if you're interested in doing research, talk to your mentors. There's a research grant deadline that ends on March 15th. That grant is through ASMBS's research committee, and it can be up to $25,000 for seed funding. Just as a reminder, don't forget to get all of your requirements in and make sure you're watching these webinars through your LMS to make sure it's easier when we get to fellowship certification time once you've completed your fellowship. After today, our bariatric happy hour will be on February 26th from 8 to 9 p.m. Eastern. And as always, these are available on the LMS. And last two announcements, the ASMBS Clinical Issues Committee is looking for new ideas and proposals for statements and guidelines in 2026, 2027. As a member, you can submit your ideas, so feel free to do so because we want to make sure you guys get engaged and are participatory in our wonderful society. Thank you, Dr. Wilson.
All right. Thank you so much, Shaina. So without further delay, I want to introduce both of our speakers and then they'll go one after the other. I'll start with Dr. Pratt. So Dr. Janey Pratt is a general surgeon who specializes in robotic surgery and the treatment of pediatric obesity with metabolic and bariatric surgery. She began her surgical career at Massachusetts General Hospital, where she was a founding member of the MGH Weight Center. As a surgical director there, she introduced minimally invasive metabolic and bariatric surgery and adolescent surgery to MGH in 2001 and 2007, respectively. In 2011, Dr. Pratt took over as a director at the MGH Weight Center and continued to work on several national committees towards improving access and care of children with severe obesity. In 2016, Dr. Pratt moved to California, where she began her work at Stanford University as a clinical professor of surgery. She was involved in training Stanford medical students and residents, both in the OR and clinic and simulation labs and in the classroom. She is the director of the Adolescent Metabolic and Bariatric Surgery Program at Lucile Packard Children's Hospital, which is an MBS AQUIP accredited program in a freestanding children's hospital. And it's dedicated to multidisciplinary care for children with obesity. Dr. Pratt has been involved in creating and updating guidelines for adolescent metabolic and bariatric surgery since 2005. And in 2018, she was the first author of the ASMBS Pediatric Metabolic and Bariatric Surgery Guidelines. And Dr. Pratt frequently lectures on pediatric metabolic and bariatric surgery, as she is doing today for us. And then Dr. Kanika Bowen-Jallow is an associate professor of pediatric surgery at TCU School of Medicine in Fort Worth, Texas. That's where I'm from, born and raised. And she serves as the Surgical Services Medical Director and Bariatric Surgery Medical Director at Cook Children's Medical Center in Prosper. She's chair of the American Pediatric Surgical Association Metabolic and Bariatric Surgery Committee and a national leader in the surgical treatment of pediatric obesity. She recognizes the lifelong impact of childhood obesity and is deeply engaged in clinical and translational research focused on adolescent behavioral interventions, technology-enabled care, and metabolic and bariatric surgery. Her work has been supported by multiple grant awards, including NIH fellowships, and she has authored over 40 peer-reviewed manuscripts and delivered more than 26 national and international presentations. And she's repeatedly been recognized as top doctor in pediatric surgery in Houstonian Magazine and is a best pediatric specialist by D Magazine in Dallas. I know that was a mouthful, but very excited to have both of our esteemed guests to lead the discussion today. So I'm not sure who was going first, but feel free to share your screen and take it away.
Okay, I'm starting off with preoperative, so let me share my screen. Okay, am I in full view mode there? Okay, awesome. All right, well, it is a pleasure to give this talk this morning on preoperative evaluation of the adolescent bariatric patient. So our objectives today are to outline the comprehensive preoperative evaluation and system level requirements for bariatric surgery candidates. We'll assess the role of medical therapy, surgical options, and patient-centered care in the treatment and planning, apply ethical and legal principles related to informed consent and patient assent, and then integrate enhanced recovery after surgery, which is ERAS principles to optimize perioperative outcomes. So I always like to start with the current up-to-date 2023 recommendations by the American Academy of Pediatrics. In 2023, recognizing the velocity of the epidemic of adolescent obesity, the AAP released a 100-page clinical practice guideline for the evaluation and treatment of adolescents with obesity and stated that pediatricians and other primary healthcare providers should offer referral to adolescents with severe obesity for bariatric surgery at comprehensive pediatric bariatric surgery centers. So why in 2023 would the AAP release these guidelines? Because we have a profound volume of literature that shows the following. Adolescents with obesity become adults with obesity and continue to gain weight. In my clinic, I highlight to parents how their children are starting at a much earlier age with obesity than they did. This means that many adolescents that we see in our bariatric surgery clinics are already heavier than their parents were at that age. Adolescents suffer weight bias and stigma. Many of these kids are homeschooled due to bullying. Bariatric surgery is safe and effective long term. And 10 years is a long time, and we have 10-year plus data now in adolescent bariatric surgery showing it is safe and effective. There can be complete resolution of comorbidities as well. So all of these items feed into the preoperative evaluation of the adolescent bariatric patient. So metabolic considerations, liver disease, nutritional status, obstructive sleep apnea, and airway concerns. Mental health is a big one in adolescents. Use of anti-obesity medications, reproductive and hormonal health, access and equity, patient education, and genetic assessment. So we can't hit on all of these things today, but we will highlight some of them. So contrary to popular belief, kids are not little adults. Physiology and end organ damage at the time of operative intervention varies from adults to children. So really, there's only two main diagnoses in common for bariatric approval, and that's hyperlipidemia and obstructive sleep apnea. Adults have a higher incidence of type 2 diabetes and GERD at the time of surgery. So adolescents have less severe end organ disease at the time of surgery. Few, in fact, have type 2 diabetes. As you can see, it doesn't even make this top list. So these are the two that they have in common with adults. Metabolic dysfunction associated steatotic liver disease is common in children, as is insulin resistance. In our female patients, polycystic ovarian syndrome is also in the top 5 for submitting diagnoses. So preoperative use of FDA-approved anti-obesity meds in adolescents. You can do a whole talk just on this slide alone. but we're not going to do that today. This varies across the United States and state to state. So that's why it gets very confusing. Commercial versus government insurance coverage varies widely. In Texas, for instance, there is no coverage for GLP-1s for government insurance in children unless they have type 2 diabetes. So it is very restrictive. As you can see on here, the age ranges for Wegovy and Ozempic, and the FDA approved for 12 and up. That's for heart disease and liver disease. Metformin is for 10 and up. We do have studies in 6 years and older. We do use it for diabetes, pre-diabetes, and polycystic ovarian syndrome. Phentermine and topiramate is for 12 and up. Mounjaro and Zepbound, that's hot off the press within the last month or two, is for 10 and up in diabetes. Topiramate, we do have patients that have migraines and seizures, and so we can use this. You can also use it for binge eating in 18 or greater. We do use it off-label use for obesity in younger children, just because it's already FDA approved for seizures and migraines. And then Vyvanse is 6 and up. This is an important one. We use this a lot in kids because there is also a component sometimes of disordered eating. And they also have ADD. So when we go through our social history, our school history, our family history, and we're finding that, they can't pay attention in school, the parents are calling their name 5 times at home, like that also has us where we can try a stimulant, which also helps with their disordered eating. So what does insurance require? You have to know what insurance requires or you will not get approved. So TMHP guidelines are from the Texas Medicaid and Healthcare Program. So I just gave 2 examples here. So there is a wide variation, once again, state to state and within the state. So as you can see for our government insurance on the left side, it's girls greater than equal to 13 and they have to be post-menses. Boys are greater than equal to 15. They require a bone age. They also require a BMI greater than or equal to 40 with a comorbidity. So our 30 BMIs of 35 with a comorbidity will not get accepted with Texas government insurance. If they do not have a BMI of 40, you do not submit because it will not get approved. They also require 6 months of regular participation in a structured dietary program in the past 12 months. This is important because if they do not get it done within that 12 months, they have to start all over again. So you have to keep an eye on all of these different requirements. As you can see for Blue Cross Blue Shield, girls, the age requirement is the same, but not post-menses. Boys is also the same. They allow a BMI of 40, but also 35 with a comorbidity, and there are no minimum nutrition requirements. So you can just see the wide variability in that. So we have about 6 of these in Texas. I have a sheet that's laminated that's right next to my desk so that we can make sure, and every provider in the clinic has the same thing, because the worst thing is to get denied because you missed one little criteria that's not even a real criteria. So you just want to make sure you only have to have that happen a couple times that you fix it quite quickly. 80% of insurances are fine with the laboratory workup on the left. So just your kind of standard workup in the evaluation of obesity. But this is, once again, we have to know your insurance. There are some that if you do not submit a vitamin K and a vitamin A, they will deny the packet. So you've submitted an entire 200-page packet and they send it back and say, where's your vitamin K and vitamin A? And you say, where's the data that makes any difference whatsoever? And they say, we don't care, do it again. So just keep all of these things in mind. They don't make it easy, but once you learn all the algorithms, you can overcome it. They most insurances require a bone age. So you can get that a couple of different ways. We do a wrist x-ray. It's low cost. It's a plain film. It takes 5 minutes for the patients to get done before they leave. But if you have access to a DEXA scan in your clinic, you can use that for bone density bone density, and it does the same thing in terms of the insurance requirement, but does give you a lot of good data that you can also give the family if you have access to a DEXA scan. Cardiac clearance. I do not routinely obtain cardiac clearance. It depends on insurance, anesthesiologists at your hospitals, and your comfort level. And so this is great that Janey's going to give her talk and I'm going to give mine, because I'm probably more, I don't know if I'm more of a minimalist, but I feel like I'm a minimalist. So we'll see, but I do not routinely order an EKG unless I'm considering a stimulant for weight loss. So that's that phentermine or that Vyvanse, or if it's required by insurance. The only time I get an echocardiogram is if there is a previous cardiac history, or there are a couple insurances that require a cardiology consult for clearance prior to surgery. If they go to cardiology, they're getting an EKG, they're getting an echocardiogram. They're always normal. Okay. They do require a sleep apnea assessment. So we use the stop bang for this because it encompasses everything that they are looking for. If the patients rank low risk, we do not refer. If they're moderate, we typically do not refer. For severe, we do refer to sleep medicine for a sleep study. This is a pretty relatively low number for us. Keep in mind, for CPAP to be effective, the patient has to wear it. And these are adolescents. And so compliance can be low. I have had a patient that sleep medicine mandated that they wear their CPAP prior to surgery. And the reason for that was because that patient had a significant history after previous operations for prolonged intubation. So they had pretty severe obstructive sleep apnea. And the way that our sleep medicine department runs, they can actually track via the machine if they're using it or not. So the fact that they get that feedback, the fact that you've given that feedback to the patient that they cannot get their operation until they have shown compliance, and they don't do a long time. I think in kids, when you're at children's hospitals, they're very reasonable. They understand children. They understand that, a couple weeks to a month is reasonable for them to be using their CPAP. They don't make them do it 6 months to qualify for surgery. And so this patient was able to do that successfully, and we were able to do her surgery. But once again, this varies from program to program. There are some programs that everybody gets a sleep study. Psychological assessment. So this is required by all insurances. It can be performed by a psychiatrist, a psychologist, a behavioral health specialist. Only one visit is required. So at my current institution, we use a psychologist. Where I came from, we had a behavioral health specialist that did a fellowship in adolescent behavioral health that was doing our clearances. So it's a wide variety. These have benefits that are far-reaching beyond weight loss. So when we get into screening of teenagers, we screen all of our teenagers in our clinic. Most children's hospitals these days, no matter what you're getting done, screen with a PHQ-9 because we have a big mental health epidemic currently. And so we do want to identify those at-risk teenagers. If moderate depression or higher, we require that they enroll in therapy prior to surgery. So that is not a requirement for insurance. Therapy is certainly not a requirement, but we can show that better outcomes come when you are treating the whole patient. I have had patients that I require to go to therapy, and they do so much better because of it. So we now have 10-year data that was published in the New England Journal of Medicine. This was in 2024. And this kind of talks about why we do sleeve gastrectomies in adolescents. And so provides data as to why we typically do not do malabsorptive surgeries anymore. Now, we started off just like everybody else doing a Roux-en-Y. But this data on our next slide. shows over 10 years, the outcomes are exactly the same. There's no difference in the type. So at 10 years, you're getting the same bang for your buck in a sleeve gastrectomy as you would with a malabsorptive operation in teenagers. And this is the percent BMI change by surgical procedure. Consent is legally required for parents or legal guardians for a minor's medical treatment and research participation. So this is not just for medical, it's also for research. Assent is a child's age-appropriate agreement to participate even if they can't legally consent. They are not legally an adult, and this also considers their autonomy when you have them assent. In clinic, I explained to the family that if they are both in agreement, then we proceed with the operation. So they verbally consent and assent in the clinic. And then when they come for their surgery, then I have the parents sign the consent, but also go through it one more time because it's good for them to hear it twice. They ask all their questions in the clinic. And then when we get to the day of surgery, they're like, yeah, I know this. Come on, let's get it on with, which is kind of nice. They're very comfortable. This is an elective operation. So I always tell the children, even at the beginning of the clinic, so it's a 6-month process for most of the children. On visit 1, I tell them, they're nervous. They are scared. Surgery seems like a big word for them. But the first thing I say is like, look, nobody's doing surgery tomorrow. Okay, this is a 6-month process. Usually they're running in there on visit 6 because they're ready to have their surgery because they've prepared for it. But I also tell them nobody's strapping you to the table. So if I have a parent that wants them to have the surgery and the child does not want to have the surgery, we don't do the surgery. Okay, and so everybody on visit 1 knows that's the way that this is going to go. If the child wants the surgery, even vice versa, and the parent does not want the surgery, of course, we still don't do the surgery. So everybody has to be in agreement about what we're doing here. So my dietitian created this on ChatGPT, which I thought was great. So she thought this looked like me and our patients. And so congratulations, you are approved for bariatric surgery in 2 weeks. And the patient saying, really, that's amazing. And time to start our pre-op diet. And she's ready to go. And this is really how they are on visit 6. They're very excited. They've had a long journey. And so once again, this is variable program to program. Some programs don't do any pre-op diet. Some do 1 week, some do 2 weeks, some only do a liquid diet. So what we've done is we do a 2-week pre-op diet. It's not just liquid because, I mean, every now and then, you try a liquid diet. How many of us are successful at that? Like that's rough. So what we do instead is protein shakes and sugar-free drinks, non-starchy vegetables. We do 1 low-calorie meal a day, high-protein meal. So they're still getting some, food intake that's not just liquids. We restrict to 100 calories a day, and they need to get at least 60 to 85 grams of protein doing that lead up to surgery. And I can definitely tell the difference when I do the surgery as somebody that's done the pre-op diet versus hasn't done the pre-op diet. Janey will tell you our BMIs at surgery are statistically higher than adult BMIs. So our average BMI is 50. Usually adults' average BMIs are around 40. And so when we're doing a BMI of 73 or in the 60s, which is not unusual for us, this helps a lot. This is guidance that we give in regards to anti-obesity medications immediately prior to surgery. So we hold GLP-1s 1 week prior to surgery. Once again, variable. I know some people that just do a day, and there's some new literature coming out that doing a day is fine. We don't restart unless it's indicated. So for our diabetics, that are on a GLP-1. We have endos see them in the hospital, but most of the time they have such a good response, and with their blood sugars, we do not restart this. Plus, we don't want to restart it necessarily afterwards, although some programs do, because of nausea. And so it helps, as minimal as we can keep their nausea over the first 2 weeks, keeps them out of the ED, keeps them out of infusion clinic. We hold phentermine 1 week prior to surgery. We don't restart that unless it's indicated. We hold Vyvanse the morning of surgery. We do restart that post-op day 1 because that is also for ADD and not just for disordered eating. We hold metformin 24 hours prior to surgery, and we do not restart that because metformin can cause a significant amount of nausea. So that's another reason we don't restart that. We do restart the Perioperative the day after surgery. That doesn't seem to cause too much nausea. So for our ERAS preoperative protocol, ERAS is enhanced recovery after surgery. This really gained traction in the colorectal patients to cut down on hospital stays and have patients advance faster in their hospital course. Does the same thing with our bariatric patients. We start our ERAS protocol the night before surgery with a carbohydrate drink of 32 ounces. If they're diabetic, then it's a sugar-free option or water. The morning of surgery, we have them also drink up to 2 hours before surgery. So they do 20 ounces at that point. If they're diabetic, same rules apply. So in our holding area, our ERAS preoperative protocol continues. We give these all in the holding area. So the scopolamine patch, famotidine, phosphopreptin. I tell you, it's a MIND, okay? I had the hardest time saying that word.
I cannot pronounce that one.
Every time. I don't care how many times I rehearse it. Celecoxib and gabapentin. So I will say for amend, this FOS that goes in front of the aprepitant, it is a version of that. It is a cheaper version. So whereas we were using amend initially, and it's hundreds of dollars, this is $75. So usually talk to your hospital because usually this is on formulary there. So that's how we figured that out. So for our intraoperative protocol, the goal is to prevent pulmonary and GI complications. So this is really driven by anesthesia, who you have close conversations with. So we do IV antiemetics prior to extubation. That includes Decadron, Zofran, and Reglan. We avoid opioids at induction and limit them during the case. We avoid nitrous oxide due to the nausea. We try not to give IV fluids in the OR greater than 1,000 mLs. We use IV ketorolac and acetaminophen in the OR, but that's all they get after the OR too. So they're on scheduled this IV ketorolac and acetaminophen. We have PRN dilaudid if needed. I will tell you 90% of the patients do not ever get it. We administer enoxaparin dose in the hospital and then the following day. The use of DVT prophylaxis is also very variable. It's very variable in adults. It's very variable in kids. We all do something a little different, but very similar. So with that, I will let Janey take it away. Thank you very much.
Thank you. I appreciate it. So several of my slides are going to duplicate Kanika's, but just bear with me. I'm just going to go through them quickly. I'm not going to talk about some of them because we did duplicate ourselves a little bit. But I left them in just for educational, and then my slide deck will be available if anyone wants to read it because it's a little dense on the ERAS protocol. But I'm going to cover the post-op management of MBS in kids and outcomes. So first of all, our program is run completely telehealth. So we used to have in-person group visits for our nutrition education, and now we do telehealth visits. We run them as a group because it's really good to have the kids interact and learn about what to eat, how to eat, when to eat, and get recommendations from other kids. So these are run both pre-op and post-op. So their education continues post-op in terms of how to eat, what to eat, when to eat. And also it covers exercise and activities. We use a standard rule for the kids called the 360s, or the 60-60-60 rule. It basically, I developed it as a way to remember how much protein and water they were supposed to be drinking and eating, because I couldn't keep it in my head. And every time I asked my dietitian, they were like, oh, it's between 64 and 80. And I'm like, how am I supposed to remember this? So I created this. It's very simple. The kids love it. It's easy for them to remember. And they're eating 60 grams of protein, drinking 60 ounces of water, and exercising for 60 minutes. And I understand that I'm mixing metric and English grams and ounces, but it's the only way the 60-60-60 works. So just get over it. We also have to make sure they stop sodas and juices. Those are one of the leading contributors to obesity in kids. Obesity is all genetic, but those don't help. So we get them off sodas and juices, off chips, and then we make sure they're not skipping meals. We also start our multivitamins pre-op. Because we're telehealth, we actually started a fund where we give every patient a scale. If they don't have a scale at home, we can't get their weight. It's a little more difficult with the heights, but every time they come into the hospital or come in for a test, we get their height. But the scale is critical because many of the kids don't have scales and can't afford them. So we send them actually a mechanical scale so the battery can't run out, and we base it on their weight. So if they're in the 200s, we send them a 250. If they're in the 300s, we send them a 350, and then so on. And the 500 scales are more expensive, but we make sure they have a scale. We also provide a water bottle now. I don't have a picture of our water bottle up here, but it has the 60-60-60 rule on it. And then we recommend they get a pill box because it's very hard for kids to remember to take their vitamins. And also after surgery, we're going to have them on other medications. So we ask them to get a pill box so they can remember to take their medications. This is our ERAS protocol in one of our early patients. I'm not going to go through it. It's very similar to what you saw with Kanika. The only difference is that we use gabapentin, and we have the kids take their Gatorade and gabapentin and Tylenol on the way into the hospital. We also give heparin preoperatively, and we use regular heparin, not a low molecular weight. And then we use methadone, and we found methadone works really well for pain control, and we've had no complications with respect to sleep apnea related to methadone. In the operating room, also very similar. We do allow CPAP post-op, and we also use SCDs on all of the patients. In the post-op period, on post-op day 1, we advanced the diet, and this is another one of our patients during the COVID era. I used to make cloth masks, so she's wearing one of my masks. In the post-op period, we start them immediately, post-op day 0, on clear liquids, and then post-op day 1, they advance to full liquids, and they usually go home. We have discharge criteria for going home. All the kids stay at least 1 night, and those with diabetes and severe sleep apnea very often will end up staying 2 nights. That's very different from the adult population, I know, but in children's hospitals, trying to get children's hospitals nurses to send them home quickly is not going to happen. And honestly, it's better for the kids. They have to have their nausea controlled, and mostly they have to have oral intake of 500 mLs before we let them leave the hospital. We postoperatively send them home on Tylenol and ibuprofen. We only give them oxycodone if they've needed extra narcotics within the 12 hours prior to leaving. So most of them go home with just Tylenol and Advil. We do send them home on Reglan. We were finding a lot more nausea when we weren't using it. The best treatment actually for nausea post-op from sleeve is Ativan. It has actually a central acting component that really improves nausea. We don't send them home on it, but we do use it a lot in the hospital. The other thing that is constipation is one of the leading complications we see in these kids. I know we see it in adults too. I think it's a little more pronounced in the children. So we do send them home on a bowel regimen. And then I do use DVT prophylaxis in BMIs over 55 and anyone with a family history or who is traveling a long ways after surgery. I usually use it for 2 weeks. If they actually have a family history or personal history of blood clots, I use it for 4 weeks. And then we put them on ursodiol, 600 milligrams once a day. This has been shown to reduce the risk of developing gallstones. We take out more gallbladders preoperatively than we do postoperatively. We have seen a lot more kids present with gallbladder disease from using the GLP-1s and having rapid weight loss than we get from surgery. And I think it's because we use the ursodiol. But I don't know. We do also put them on Prilosec, and those two are for 6 months. The vitamins regimen is similar to adults. We use pediatric chewable vitamins. They get really tired of them, so we transition as soon as they get tired of them or complain about them to bariatric multivitamin. And then 2 calciums. They put them on extra B1 and B12 for 6 months. I have seen kids post-op develop B1 deficiency within 2 to 3 weeks of surgery. So if your kid goes home and they're having vomiting, you really have to make sure they're getting that B1 because they can develop vitamin deficiencies very quickly. The post-op diet advancement is similar. This is not ours, but it's close enough. It's basically the same as in adults. You're going to do, a couple days or a day of clear liquids. You're going to do full liquids for 2 to 3 weeks. We only do 2 weeks. This says 3 to 4. Some kids do need that. And then pureed food for a week, soft food for a week, and a regular diet. This is again not my diet protocol, but you can use whatever you want. You want to watch out for complications. The complications in kids are similar to adults. The nausea and vomiting is the biggest one, and then constipation. Pain in the first week is not too bad. The kids are really pretty decent. We do them laparoscopically. You can also do them robotically. I think that has a little less pain, but when we get a robot, we'll be switching. The complication rate is extremely low. We do an intraoperative leak test. We don't do swallows. When I first came to the hospital, they were doing swallows, putting in Foley catheters, a lot of things that we just don't do anymore. We basically never use Foley catheters for sleeves or bypasses. Kids do fine. We've not had a case of urinary retention in the 10 years that I've been practicing at Stanford. We use prophylactic antibiotics, 3 grams of Ancef, and we watch for internal bleeding and we watch for blood clots. Blood clot risk is much lower in adolescents, but it still can happen. It's extremely low though. In terms of late complications, again, same as the adults. There's a risk of hernias. There's a risk of nutritional deficiencies. There is dumping syndrome. Again, don't see these very often in kids. We do see nutritional deficiencies, but if they're taking their vitamins, I have several kids I've had to take off vitamins because their B vitamin levels are so high. So, some kids absorb really well and don't need them. Most of them do need a multivitamin. The reaction to rapid weight loss, I'm sure you've seen it if you've been following patients in clinic. It's usually they're tired, they get dry skin, they get some hair thinning, changes in mood. Those are pronounced in kids. So mom and dad will be like, this kid is crazy, she's really moody, or he's really moody. And I just say, listen, that's part of the rapid weight loss. It's going to get better. And it does. It does settle out over the first year. Inadequate weight loss and weight regain occurs in about 10% of kids. And it just requires regular follow-up, regular physical activity, and then early reinstitution of obesity management medications. We can put back on Wegovy or tirzepatide early if we need to, and very often we do. In bypass, there's a risk of obstruction, gallstones, kidney stones. It's the same as in the adults. risk of alcohol addiction, same as the adults, but this is probably a higher risk population. So in a kid I'm going to do a bypass on, I'm very clear about the risk of alcohol and drug addiction, very clear that they really need to avoid alcohol and drugs. And if they are going to try them, to do it in a very safe environment. And then avoiding nicotine is also a huge thing with the kids. Many of them vape and smoke, and so we have to be very careful about that. In the sleeve, we see more, we do see reflux post-op in the kids. Usually it's just controlled with omeprazole or Prilosec, and it's not a big deal. We wean them off at 6 months of the Prilosec, and if they develop reflux, then we restart it and we scope them in 6 months. The gallstones, again, we don't see much. We do use ursodiol post-op. Our post-op care is similar to adults. Again, we see them at 2 weeks, 6 weeks. At 3 months, we check their labs. At 6 months, we check their labs. If their B vitamins are good and they're clearly taking their vitamins, we stop the extra Bs. And then we see them annually after that. We do repeat the sleep studies, and we get a DEXA scan pre-op, so we repeat that at 1 year. It's always important to remember that kids need transition of care. So if you're going to transition them, you want to communicate with their primary care. It's usually a pediatrician. You have to decide when you're going to transition them. They may be transitioning primary cares at the same time. So if they're moving away from their pediatrician and to a new primary care, you want to make sure that you're informing that person how to take care of them. You want to tell them to be checking for vitamin deficiencies, asking about night vision, asking about bruising, asking about numbness or tingling in the hands or feet, ataxia and double vision. All of the signs of vitamin deficiencies, you want them following. You want them to screen for reflux. You want them to know that abdominal pain and vomiting are not normal after bariatric surgery. Some doctors don't know that. So make sure they know it's not normal. Send them back to me if they develop that. If they need an adult bariatric surgeon, you want to refer them to adult bariatric program. If they're on medications, you want to refer them to an adult who is prescribing medications. You want them to ask about risk-taking behaviors, body dysmorphic symptoms, and eating disorders. Kids are much more likely to redevelop eating disorders after surgery. We've seen ARFID, which is a fear of eating and excess weight loss. We've seen restrictive eating. You can see eating disorders post-op, and so you just want to be aware and screen for them. We want to make sure that they know that these kids can have plastic surgery, and over 60% of them will do it at some point in their lifetime. So refer them. If they have inadequate weight loss, you want them to know it's okay to start obesity management medications after surgery. In fact, we can start them as early as 2 weeks. So if they are not losing weight, or having a lot of food noise, it's okay to restart their medications. And then you want to watch out for pregnancy. Some kids do get pregnant after surgery, and you want to make sure they're taking their vitamins, and you want them to annually monitor their labs. And so it's important to have a transition of care program. The AAP lays out a 6-step stage to transition about setting an age, and so make sure your program develops a policy and a plan to transition kids. So what are the outcomes? First of all, why do we treat children with obesity? Because there's a 3-fold increase in mortality by age 30 in children who have obesity. Okay, so the reason we treat it is because childhood obesity will kill young adults. So it's important. We know that bariatric surgery increases life expectancy. This used to only be adult data. They've now shown the same thing in children. So we know that we're going to get a longer life expectancy. We don't know the number of years in kids, but we know that you're going to live longer if you have bariatric surgery for your obesity. The adolescent obesity studies have been done for years. This is one of the first long-term studies that compared adults to adolescents and to lifestyle change. This comes out of Sweden. And the AMOS study basically showed that adults and adolescents have the same outcomes at 5 years. So you don't get any different outcomes. This was with bypass, but you don't get any different outcomes. They also showed 72% developed nutritional deficiencies. Now, I always have a problem with these because that is lower than our rate of pre-op nutritional deficiencies. Every single patient has vitamin D deficiency pre-op. So I always wonder, like, what does this mean? And I think that if kids are compliant, they really don't often get vitamin deficiencies post-op that they didn't already have pre-op. The largest study in the US was the Teen Lab study that Kanika already showed you the 10-year data from, but I'm just going to tell you about this study a little bit because it's important to know when you're talking to patients. It's 242 consecutive patients in 5 institutions, and this number actually went up to 267 because they added some sleeves. There are actually 80 sleeves in the final analysis, and 131 80 sleeves and 161 bypasses in the 10-year data. What they found is that sleeve and bypass had the same outcomes. There was significant improvement in comorbidities, significant improvement in health-related quality of life. They did see some vitamin deficiencies, and the sleeve and bypass had equivalent weight loss. And again, this is why we use both of them. They also compared it to the Today trial, which was diabetic youth, and they found that in diabetics who were taking medications for their diabetes, that we only saw weight gain, whereas we saw weight loss in the Teen Labs patients. And we saw resolution of diabetes. This is the Teen Labs patients. This dark blue is normal. So Teen Labs we were at 2 years, 75% of the kids had complete resolution of their diabetes, pre-diabetes, and had normal A1Cs, whereas only 10% of those in medical treatment had a normal A1C. Even on medications. So it's clear that that for diabetes in kids, this also works better. This is the 10-year data that Kanika showed. Diabetes, hypertension, and triglycerides were equivalently improved by sleeve and bypass, and the sleeve had fewer B12 and ferritin deficiencies. This is the most interesting data that we have from Teen Labs, though. I love this slide because what it shows is that patients do differently. That 50% of patients will have an average 36% total body weight loss at 10 years and maintain it. So that's excellent. Those are the kids that we don't necessarily need to use medications. Although, as Kanika said, many of our patients are coming in with BMIs of 60, 70, 100. So those patients are going to need surgery and medications. But what we did find is that at 6 months, we can predict who's going to fall into this red or blue line, who's going to have inadequate weight loss or weight regain, and we can start medications at 6 months. So in our program, we screen for these kids in the red and blue, and we initiate medications early to keep their weight coming off. So we don't see kids in this place anymore unless they're lost to follow-up. So those who are following up stay down in this area because we initiate medications early. The other thing to understand is that it's different on adults than kids. In a single center study of 76 adolescents and 74 adults, Dr. Fatima Cody Stanford looked at the patients that I had operated on, and the average BMI for adolescents was 50. The average BMI for the adults was 44. And this is when I was doing adult surgery. This is all the same surgeon, same institution. These were back in Boston. And we saw that the percent total body weight at 4 years was only 19% in the adults, and it was 28% in the children. Same operation. Okay, so kids respond differently to surgery than adults. Now, I had a very an older population too. The average age was 55 in this. But we also found that they were 87% had diabetes resolution, 68% had hypertension resolution, which was different than the adult population. So kids were more likely to respond to the surgery, both metabolically and with weight loss. The largest study in adolescents comes out of from Dr. Al-Khattani out of Saudi Arabia. He has done over 2,500 sleeve gastrectomies in kids ranging from age 5 to 21. He only had 2 leaks in that population, He had 3 patients develop neuropathy from B1 deficiency, and he had 22 patients with prolonged nausea. Those were the only complications in 2,500 patients. He also demonstrated that they had improvement in diabetes, hypertension, dyslipidemia. They had 70% excess weight loss at 10 years, which is basically comparable to the Teen Lab study. And they had normal growth velocity. So often parents will be worried, is this kid going to grow to their expected height? And actually, the younger kids even grew a little bit taller than their matched peers. So normal growth velocity is part of this. It does not inhibit growth velocity. It actually normalizes puberty. So even if you're doing these operations in kids who are prepubertal, they are more likely to have a normal puberty onset than they are with obesity. Obesity messes with puberty onset. It delays it in boys, it makes it earlier in girls, and this fixes that. So you're more likely to have normal puberty with this operation. This is an example of one of our kids. This kid is 11 years old in this picture. He's 12 in this picture post-op. He has gone on to have a biliopancreatic diversion at age 18. We basically kept him kind of okay until then, using medications and on top of the sleeve. But this is both of his parents have both had biliopancreatic diversions in the past. Very strong familial history. I wanted to give a couple of examples because it's different looking at kids than it is at adults because we look at a growth curve. This is what a growth curve looks like in kids. These are 140% of the 95th percentile. These are the numbers that we look at. And you can see at 10 years old, a BMI of 26 or 24, whatever this is, it's about 26, is actually obesity. Okay, so in children, you're looking at lower numbers and recognizing that that is obesity. So this is a kid that developed obesity around age 10. He was Hispanic, he had a BMI of 40, and he had insulin resistance depression. She had insulin resistance depression and PCOS. We did a sleeve gastrectomy. She lost some weight, but she started to regain, so we added Wegovy, and we got excellent weight loss, got her down to a normal weight. So the combination of Wegovy and medications got her to a normal weight. This is a 12-year-old who had had obesity since age 2, and you can see the BMI was 39, but the percent was 150% of the 95th percentile. In adults, 140% corresponds to a BMI of 40 and 120% to a BMI of 35. So we use those as our cutoffs. We use the percent of the 95th percentile, and that's what they look like on the growth curve. So this kid had 150%. And what we're looking for in kids, if they're growing along the growth curve, it's probably okay. It's when they're crossing the growth curves that we get worried about them. So this kid lost weight, kept it off, did really great. Both his sleep apnea and steatohepatitis resolved. Another kid was a 16-year-old Black female. She had a BMI of 54 and a weight of 325 pounds. She had also had obesity since age 2. She had severe hypertension, sleep apnea, insulin resistance, steatohepatitis. These kids are not well. They all have comorbidities. All of the kids we see have comorbidities. It's not, there's a reason to how we operate on them. This kid had, her BMI was 190% of the 95th percentile, and she lost weight excellently just with surgery. This was a sleeve gastrectomy, and continued to lose weight at 3 years post-op. And finally, this is a young Hispanic man who I met when he was 15. At 16, he underwent surgery. He had a sleeve gastrectomy, had excellent weight loss, but then developed weight regain. We added Wegovy, and he had somewhat weight loss over the next 2 years, and then came back and we did a bypass. I know bypass in adults is not used for inadequate weight loss. It is quite effective in kids. If they had a good response to the sleeve, they usually have a really good response to the bypass. So when we don't see adequate sustained weight loss with the sleeve, we do add the bypass. And in the bypass, we actually did add Wegovy because he started to regain weight. So he had a bypass and Wegovy, and he's kept the weight off. He's now 21. And so MBS medical anabolic and bariatric surgery, usually the sleeve provides increased life expectancy, improved quality of life. It's more effective in kids than adults, and it results in 95% improvement or resolution of comorbidities. Another patient of ours is online, and kids really take this. It really changes their personalities. They have a better life. They're not bullied. They just live. They live longer and they're happier. So I strongly recommend that you make it part of your practice when you go into bariatric surgery. If you're in an institution, do it for the kids. See if you can add it to your practice. Make sure that you're taking care of them. Thank you.
Thank y'all very much for this wonderful talk. So I always measure how much I've learned based on how many screenshots I took, and I really appreciate education and the amount of memory I used today. So thank you very much. We had a question in the chat regarding, and Dr. Bowen-Jallow, I do appreciate you answering on the fly. Wanted to give both of you, Dr. Pratt, also an opportunity and you to maybe comment further. Regarding thiamine deficiency postoperatively, do your pediatric patients get scheduled thiamine while inpatient for their procedures? Curious to hear your answer, Dr. Pratt.
I don't do that, but that sounds like a great idea. Why not give them a banana bag while they're there? I like that plan. Maybe.
Yeah.
I don't. We over the 6 months tank them up, so they come into the surgery, pretty good. So
yeah. Oh, thank you. Curious a little bit about nicotine testing. I always, for me, that's a huge, in adults, it's something we always test for prior to surgery. Do you guys do any nicotine testing in pediatric populations, especially considering, to your point, the vapes that are used that are a little harder to identify?
We have a really good psychologist. She gets out of them whether they're smoking or not. So, if they're smoking, and very few of them are, honestly, most of the kids are not smoking. They are smoking marijuana. Most of them are smoking marijuana. Most of them are not smoking vapes. So the only thing that I have seen in some of our patients is cannabinoid hyperemesis syndrome, which we've had in 2 patients. And so we do recommend stopping cannabis, and we do warn about hyperemesis. I would educate yourself about that and about eating disorders if you're going to take care of kids, because those are the 2 things that we see in kids that I had to learn about that are quite different.
yeah, we just asked the question. I asked them about vaping. The kids are actually pretty honest. I mean, and you can tell when they're lying. I mean, Judge Judy has a famous line where she says, "You can tell when a child is lying because their mouth is moving." So
They are terrible liars.
they're
It's really
terrible
easy.
liars. Terrible. You'll
It's
say,
so much better
right,
than adults.
you say, are you drinking? Are you doing any drugs? Are you doing this? And they pause, and you know instantly that they're doing it. And so then it just becomes, well, what are you doing? And then everybody in the room gets educated what's going on, including the parents. So we do make them stop. I tell them while they're vaping, I won't do the operation. I explain why. I show them pictures of the lungs, and they ultimately will stop. But we do, but just like Janey says, they get psychological testing. So we put that in their note. They check for that when they go for the testing. So they're at multiple levels. They're being screened.
So nonverbal autistics and kids in general with autism do really well. I will say that they actually, in our studies, they do better than neurotypical kids. And a part of that is because they follow rules. So you tell them they have to do something, they will do it. The only exception is if they are nonverbal and they're really combative, or they can't keep an IV in, that can be a problem. So what we have done, because we do pre-op endoscopy, is if a kid, we don't know if they're going to be able to stay overnight in the hospital with an IV, we do a test. We keep them overnight after the endoscopy, and we put an IV in, and we run the IV overnight. And if they successfully do that, then we move forward with surgery. The other thing they have to successfully do is a weekend liquid diet trial. So we have the parent see if they're able to keep the kid on a liquid diet for the weekend. So in the severely autistic, nonverbal, really difficult to communicate with, that's what we'll do before we move forward with surgery. And we have had 2 patients, one who was really incapable of keeping an IV in, who we did not operate on. And there are occasions when we think that the operation's not as safe, we can't keep them safe afterwards. And the parents will be like, well, can't you just sedate them and keep them in the PICU? No, that's not something I'm willing to do. I don't know anyone who's done that. But now we just use medications, and it's not as good. It's not really adequate in some of them, but it really, we don't want to do an unsafe procedure.
No, I agree with Janey, and our patients who are nonverbal, especially if they're high functioning, they do so much better than our neurotypical kids. And so, and to mirror what Janey said, I mean, I've had one patient that we said we're not going to do surgery on, who was a Down syndrome, and it really wasn't the child; it was more than the parents. They wouldn't do the shakes. They wouldn't, and I'm not super strict, but like you need to find a shake you like. You need to be able to do the shake, and if you can't do that, then we can't do the surgery. So there are some caveats.
Right.
So kind of along those lines.
Laura, there's no training except attending things like this. You can get training. The only thing I would say that you might want to do is motivational interviewing, because I think that's excellent training for adults, but it's really helpful in kids. So I think that might be something that helps. In terms of the psychosocial elements, they're kids, they're teenagers. If you know anything about teenagers are unpredictable, and they have their moods, and they need a lot of reassurance, and they have a lot of anxiety. And that's the fun part of it. That's what I like about it.
I feel like we have a bunch of kids. I mean, there are a lot of family dynamics. So I will say I certainly have kids who their parents are hardly involved. And then it becomes really, I mean, they make their appointments, but they'll be on their phone, or you try to call them, they won't pick up the phone, and basically the child is taking care of themselves. And sometimes that works, and I've had kids that are doing great because they've been taking care of themselves their entire lives. So all the dynamics are very interesting. And I will say, so Janey, you said about the keeping the kids 2 days. I don't keep the kids 2 days. 99% of my patients go home the next day. My diabetics do stay. My diabetics stay 2 days. But we do a lot of work in the clinic, and it's like an expectation. It's like sitting home in Appy afterwards. Like you come into the ED, the first thing we say is you're going home.
Yeah, all the kids go home except the diabetics, and the severe sleep apnea sometimes don't have that oxygen saturation to leave the hospital yet.
Yeah. So I'm curious a little bit about kind of the post-op follow-up a little bit. So as you know, we're asking about the psychosocial in the family. One of the things we have struggled with in our own program is post-op patients showing up for appointments either in person or virtually. How do you get the kids to show up for post-op appointments, or what do you guys do there?
You call them when they miss it.
They harass them. Yeah, it is true with kids. It's like raising more children. I mean, we are on them like right on rice. It can be painful at times. But since they are kind of your children, it's probably a little bit different investment, and you get worried about them. We had my first patient that had gone through 6 months of the program and was supposed to start their pre-op diet and ghosted us. So most people would have been like, whatever. Like, no, everybody was calling every day. We were about to call 911 to make sure that, get proof of life. And it turned out what had happened was that the mom had come to the realization she couldn't afford the supplements, she couldn't afford the shakes, and she was embarrassed. What does that mean? Then we need to go get a grant so that we get these shakes. And so that's what we're doing because, everybody should have access.
We have called 911. Actually, we've sent the cops out to find our patient because like the patient wasn't answering the phone, mom wasn't answering the phone. We're like, go check on this person. So we do. You call them. You just call them. You keep track of them and you call them and you make sure they're coming back.
Dr. Wilson, take it away.
Yeah, excellent info. The only quick question I had with the sleeve and bypass maybe being equivalent, do y'all give any consideration to limb lengths? BP limb lengths is a debate in the adult world. Should we make it longer? Will that allow for more weight loss? Are you more conservative in children? What is y'all's practice on that?
I've always made 100+ limb length,
For
100,
BP?
120, somewhere in there, BP limb length.
Okay.
And I just do that.
Got it.
I continue to do that. I've never had a shorter BP limb. I mean, when I first started in open surgery, maybe it was 20 to 40, but since I've been doing bariatric surgery, I've been making 100 limbs because that's the longest mesentery, and I want the least amount of tension on my anastomosis.
Gotcha.
So the longest mesentery is somewhere around 80 to 120. So that's usually where I put my limbs. But we don't do a lot in kids. We really don't. There is some emerging evidence that in the hypothalamic children or we didn't really go into genetics, and obesity in children is different than adults. It responds differently. It is different. So you can't take these curves that we showed you and apply them to adults. They don't work. Adults are different. And also you can't take the risk factors that you have in adults and apply them to kids. They don't work. The kids that get readmitted are the kids who have diabetes insipidus from hypothalamic obesity. They're the ones that you can't manage their post-op volume, and they're going to come back in at 1 or 2 weeks post-op for volume. So it's a totally different population. And basically, if you come to some of the more in-depth talks about pediatric obesity, you'll learn that. And that's all you really need to know in terms of education. That's what you really need is more talks about pediatric obesity because it is a different entity. And we didn't get into that, but there are different risk factors. And we see kids with congenital heart disease. We see kids with post-transplant, just like in the adults.
End-stage renal disease.
End-stage renal disease, yes. So all of the things that you see as adults are similar, but not the same. The other thing is that a BMI of 60 in a male patient who is a kid is not the same as an adult. When you go in, that kid's going to have a thick abdominal wall. It's going to be an easy case, just as easy as any other kid with a BMI of 60, male and female, the same fat distribution. It's not like the men where you're going to get in there and you're going to have a thin abdominal wall and a ton of intra-abdominal fat and be struggling for hours. It's not like that.
Listen.
It's a very different population.
Okay. And I think thank you for answering that. And I think we're out of time, but we do want to thank both of you, Dr. Bowen-Jallow and Dr. Pratt, for sharing your expertise. And I know this will be a really valuable lecture for our fellows and trainees to look on even after this. So thank y'all so much. And thanks to everyone. I forgot to say Happy Black History Month. And hope you all enjoy your Friday and weekend. Until next time.
Bye.
Love it. Bye.
Thank you, guys.